Please, Dr. Okezie, please have a recognize. Thank you. So good to see you. We also have what we call the CANPAD has regional reps. So reps, for CANPAD right here in Ontario. So without further ado, thank you so much. You're welcome. There'll be time for me to talk a bit. We are so grateful for you for coming over here. Really, really thankful. The cost for the exhibition is $50 this year. Next year, probably going to be $500. We know you guys are capable of doing it, right? So this is Ontario, right? So money talks, yes, so that is possible. So I'd like to call on our moderator, Dr. Rebi, to take it off from here. Thank you.
Thank the officials of CANPAD for having me here. Thank you all for coming here again on Sunday morning. And thank you again. The next 20 to 25 minutes is going to be quite interactive. I'm going to be talking about the common pediatric cases that you see in all your clinics. Okay, so we're going to be interacting. Everybody is going to contribute, okay? So I'm going to see what you guys do. I'm basing this mainly on the CPS guidelines. The CPS is the Canadian Pediatric Society. So they have what we call position statements. They are the evidence-based guidelines. Some of you might not know, but it's true. You can go online and see the evidence-based guidelines on managing most pediatric conditions. Very similar for those that came from the UK to the NICE guidelines. So that's what they are. So most of my teaching today is based on that. So sometimes we do what they say, sometimes we're not, but we'll find out all that now. So the next few slides will be tummy issues. I'm sure some of you are already guessing what these are. These are a very common presentation of babies. I've said newborn, but really this is within the first 3 to 4 months, okay? Babies come with brief I'm going to discuss now. Very, very important to take a thorough history. The history is very important. You need to be able to differentiate each of these conditions because the management is different for all of them. Okay, which of these is not suggestive of infantile colic? Incontinence, persistent crying, with forward gain, swimming with motion, clenched fists, going legs to chest. So the next few slides will be tummy issues. I'm sure some of you are already guessing what these are. These are a very common presentation of babies. I've said newborn, but really this is within the first 3 to 4 months, okay? Babies come with these three I'm going to discuss now. Very, very important to take a thorough history. The history is very important. You need to be able to differentiate each of these conditions because the management is different for all of them. Any other answers? B, yeah, the answer is B. Okay, so most of infantile colic, they're sort of arching their back, they're very unsettled. Persistent crying, poor weight gain, you shouldn't see that in infantile colic. With failure to thrive might mean other things, so it's very important to examine this baby and rule out the other red flags. Now, what is the most effective strategy in managing infantile colic? So I meant to conduct your oval and your infocol, that's the symmetric bone drops, soy-free formula, parental support, switching to lactose-free formula. C, very good. So very important is support for the parents. Parental support, colic is self-limiting, medication changes, recommending medication and changing the formula is not the route. I'll give you an example. I see a lot of this in my walk-in clinic. Life formula is the first line. Amino acid formula is reserved for severe cases. Okay, so in Ontario, or at least in the GTA, the milk, the ones available, Nutramigen. Okay, you're all familiar with Nutramigen and Similac alimentum. There was a time when there was a shortage of a Similac alimentum, but these are the two now. When should you introduce? So I'll talk about when should you introduce? So you've tried this form. Mom started with the milk within about 3 to 4 days. The blood in the stools all clear, things were better. When should you introduce the milk? Any thoughts?
See.
Ideally, what would you put them on the milk, but it's a non-IgE mediated allergy, the cow gluten allergy. So you try them on the elimination, and then you challenge them for 4 weeks. Okay? But in practice, most people leave them on it. Also, most parents, once they see that resolution, they're like, why did I go back? I believe this is evidence that you put them back on it and see. What are some of those things I mentioned in the other slides there, okay? So you put them back on it and see. If they have the same reason, you put them back. But most parents are very reluctant to sort of do the challenge and then elimination and then re-challenge. Okay, your comment is then that 4 weeks after elimination to confirm that much as they made the milk, some of the nutrients are not equally as the other milk, so they don't want to avoid unnecessary restriction. Okay, so these are some table points. So what breastfed and formula fed babies can have cows with protein allergy. The way to manage them is discuss, essentially analyze and assess mind, avoid soy formula in children less than 6 months, and then involve the dietitian if needed. For baby with frequent feet-ups, no red flags, going on just says, oh doctor, baby's about 2 months. Usually he has his feet, he has to spit up, you know, like half a spoon. Seems happy, some feet he spits up, some feet he doesn't spit up. Very unsettled, very irritable, the growth is normal. You initially try the thickened feet, you know, there's some prepared ones that people spit up, and there's some other additions you can put to the milk. Baby has not settled, baby is not playing well, mom is very frustrated. So what would you do now? What would be your next step?
Yeah, sure. Hey.
You all happy with B?
Yeah, B.
All those for B.
Dr. Ariya, thank you.
Thank you, Dr. Adibari. Please feel free to go to the back to engage, because that's how we all not pay tax. We don't want to pay tax, so I'm sure you'll tell us more about that. I'll leave that in your hands. So the next agenda is amount, about 50%. So we appreciate you guys. We appreciate you guys. We appreciate you guys and thank you for coming. So we're going to call upon the next presenters. That's Dr. Rosemary.
Yeah, Nigerian trained international medical graduate, integration into medical practice in Canada. Every one of us here came as an IMG, but we all came with different pathways, different routes, and we all got into practice through different avenues or pathways. So I am also an IMG, so this is my physician perspective as per how I have helped and what we had to do. So the objective of this presentation today is the importance of IMG mentorship, understanding the aim of ITPO or CISO, applying the specific steps involved with ITPO or CISO, benefit of Nigerian trained IMG involvement in the program. So back in the 70s, the Canadian government felt there was no physician shortage at that time. They had so many physicians to patient care, and they felt they had too many medical schools, and some of the medical schools were closed, and they now cut back the number of students going to med school. So with that act in the 70s, we now have a shortage of over 22,000 difference in demand and supply of physician to patients. So we are having like 1,300 graduates every year. Compared to that demand that we have about over 13,000 physician deficit at the moment. So we have IMGs that are physicians. Patients are you providing chronic disease management for? How many of those patients are you seeing for preventive health care? Because we don't want to treat when there's disease, we want to prevent, which is what we never had that opportunity to do in Nigeria while we're home. Now you get the chance to do this. So you're cutting back on the patient doctor scarcity in your community, and also you're reducing the work burden on yourself when you take on a clinical assistant who is an IMG, who already has medical knowledge. Don't go and take, sorry, let me look around. Don't go and take those physician assistants that just went through Niagara College and then you think that they will have the same knowledge as you. No, they don't. Okay, you have to if at the end of the day you see that you're going to be solving a problem in the community, when we help the IMGs to integrate into the health system, there's more than enough opportunity for everyone to have access to patients. There's no like, oh, I only have 1 million here, so I don't, or let's say 1,000 patients here. So I don't want more people to come in so we don't have to struggle for patients. There's nothing like that. There's too many patients in the community looking for a family doctor, not just any family doctor, but a good one. And we should give our IMGs the opportunities to get into the system and demonstrate what knowledge they have. And of course, they have opportunities to get trained. So, finally, that's all I have to say. Dr. Natalia Odude.
There was this thing here. I was worried because I've got ADHD undiagnosed. So this is what's going to happen. So I was thinking I was going to fall off. So my slides will come up now. Airport, arriving in Canada. So was that an accident? Was that fake? Because actually, now they'll tell you, I had issues with concentrating, but it became something else. And I'm not too much of a ladies' man, but I became a people person, and I follow that passion. And so that you can see that MBBS only 3, but there's actually more inside. And if you notice any ADHD traits, they are also invited. Anybody, you all have something to give. I think that's the message here. So whether you're the one that got degrees or not, you have something to give, and I have something to give. And I've got an IMG. So this is an IMG. So Nigeria, UK. UK for 18 years, Nigeria for about 6. And I met somebody before I went to UK. So that's the real story. So why do they matter? Rosemary has covered the statistics. You know the people that go to school. Statistics, 2%, 3%. I don't know the number. All I know is somebody's here. I want to empower them. I don't care about the number, just come. I've met a few IMGs here. If I've met you before or spoken to you, you can just give me a show of hands, just to give me some encouragement. How? That's passion. It comes from the belly. It's not something to be boastful about. It's just who you are. So each person has something they have. So their story, then it becomes our story. Stories are very good because that's part of community. I'll demonstrate this to those that don't know the community well in 2 seconds. What is needed, who is needed, making it happen. That's essentially what it is. Let's get it done with everyone putting their hands together. So, you see, you have to renew your mind. Say amen. So community starts with one person. If I fall off, pick me up. It starts with one person. And then it grows. But when an ADHD person or undiagnosed tells you the take-home points at the beginning, it's because they're all over the place, where they calculated to give. Then you go, you come in, you grow, and you motivate the next person that's going to grow. So go, grow, and motivate. You can't stand still, like ADHD situation. So, you renew your minds. The things on that list, there are things that either you have it, self-centered, or someone is the perpetrator to you. Whichever one it is, recognizing it and trying to fix it. Bias, distrust, apathy, empathy fatigue, you're stressed. Of course, my own, let me just do my billing. Because I mean with MMG, is she good? Can I take her or not? Those are the things we need to unwind. What are you really doing? So my dream, I was in hospital 5 days after arriving here for a week. That's the sad part. But I'm here today. I was ill. And I looked at Open Trafalgar. There was no black person walking around this place. I mean that not to be sectionalist. Fact. We want to change that. So for those who are familiar with slogans like Black Lives Matter, it doesn't matter if you're just carrying placards. Your 7-year-old needs to see Dr. Really on TV, marching about the place, jumping. I'm a shy person though, but when you follow your passion, I don't really, they're not intimidating me yet. Nothing is happening. So renew your mind. Now, if you look at that, we're all looking in. So look in, forget your billing, forget your pay. Money will come. They'll sell you RSPP, PSP. Money will, it could be up to you, up to me, up to them, up to us here. But actually, it's irrelevant. If all, so we are doing something. Does that make sense? So we remember take-home points already given at the beginning by an ex-ADHD, then ADHD. The point is, you go, don't stand still. You grow, and you motivate someone else to grow. And that's it. Spirals. So once upon a time, that's Naija for you. If you don't know that, then you're not a real, that's the community, that's the signature. Once upon a time, time. I'm very aware of a young man who met a doctor in the early. He met this doctor who had trained in England. And he sat with that doctor after he had done a few years after qualifying. That doctor gave him a taste and day-to-day of what happens in England. So that's our first part. He paid for 5 exams for that doctor. USMLE, TRAS, Ireland, PLAB 1 and 2, CSA. The doctor moved to England. In England, in 2007, according to that doctor, when MTAS conversation, the doctor didn't get a job. He came back to Nigeria, where they had done a send-off for him, continued to work. He came back when GMC said don't do anything. That doctor did not do any shelving, any security job. Doctor just came back, and when it was time, sent him back. Now, the point I'm trying to make is, you pay for someone's exam. You gave them all your documents together to get visas, etc. That doctor cannot do anything else, because it's never happened before. That doctor is me, let me just ADHD for you. That's me. I arrived UK, no exams were difficult, because I've been practicing like in England. Before I got my first job, chucked me into someone's place for clinical attachment, urology. Sat there, easy life. He came to England thrice to give me money. To whom much is given, so there's no, I can't do anything else. So I've let the cat out of the bag, that's me. So, and it's still today, it's my mentor. He thought I would be a urologist, but I told him no, I'm a people person. Right, once upon a time, I arrived in Canada, I saw big people with big bank accounts. I didn't know what was going on. But I was just feeling unsettled. My colleagues were billing. But I was restless. Does that sound familiar? I said, where are these IMGs? And I went, I found my way, and I met them. We had a short meal together. Today we're a small network. You see? And it grows, you can't stop it. And it's effective if you channel it well. So if I don't have a degree and I'm sharing with you, you leave today and you remember to go, just go. Then you grow, then you motivate, then it will happen. And the network began. Yeah, I think you should hear their story. Unscripted. So I'll give my clinical assistant, Shekinat, she's 4 weeks with me.
Hello, good evening, good afternoon, everyone. My name is Sekinat. I'm Dr. Clinical Assistant, and then I am an IMG from Nigeria. I studied at Olabisi University. I know there will be few number of OSUites here, ex-OSUites. So my journey to Canada has actually been a little bit difficult and also incredible. And I met Dr. Olude just a few weeks from now. And when I arrived in Canada, I also met some few amazing doctors. I would say Dr. Oluwatosin. She was actually my stepping stone when I arrived here. And then she introduced me to Dr. Olude. Meeting Dr. Olude has actually been a very amazing experience. I could say that he has been the first person I've seen who generously give an ING a token to come and attend observership at his place. I've never had a mother before. So even with that, me having to transport myself from Mississauga down to St. Catherine every day just to work as a clinical assistant with Dr. Olude. One day I told him, Dr. Olude, I can't continue for like 1 hour, 2 hours. And he said, no, Sekinat, you can't stop right now. I'm going to help you with something again. I was like, wow, who is this person? And he actually is still in helping INGs, helping us as in achieve our dream, and also the struggle of paying for exams and all of those stuff that I've faced. It's actually challenging. So I want to encourage our elders here to please accommodate us. I know there are a lot of INGs there that our hands are really open to training, and Dr. has been an amazing person to me for the past 4 weeks. And then we actually had like very second I do this. I said, Dr. Olude, I'm trying, but the last 1 week I just turned the new leaf and I was like, you actually be an amazing person. So I also want to encourage all the INGs here. I know the job is really difficult, paying for exams, having to even take some menial jobs just to survive. If I am, you know what I'm saying. And I want us to keep holding on, keep the fire burning, and then I believe there will be light at the end of the tunnel. So let us be there.
That's what we're saying. Thank you. Building your community. So the struggles, everyone deserves a safety net. The better the net, you can slip through or you can fit in. That's just what that's about. Why care? You can see why you should care. Who cares? All of you. What does it take? You heard from Professor Rosemary, who have been here for a long time. So you've heard what it takes.
Thank you for what you're doing. I'm actually thinking of getting a clinical assistant, but I wanted to ask about verification, safety. I mean, they'll send their CV, but in terms of like being sure people are who they are, they're like legal doctors, wherever they're coming from. How do we go about that? That's one. Second, things like, of course, we talked about supervising, I think he's on us, isn't it? But things like, if there's like a significant error or something like that, what are the ways that we can make sure that does not happen? But basically, what do we need to see to be safe? Because everybody that says they're a doctor, you don't know what's happened, isn't it?
Risk for asymptomatic AF. That's where I was going with all this. Remember, patients who have AFib with symptoms, you don't have to worry. They will tell you, doctor, the thing they will feel like this. Doctor, I am always, my heart is beating very fast. Sometimes I feel dizzy, that's a different topic. I feel lightheaded. Some would be lightheaded, they will say they're dizzy. Some would be dizzy, they will say they're lightheaded. So it's up to you as a physician to try to clarify and figure out what do they really mean. Okay, so they said the definition for their study was of frequent PAs was inconsistent in all the data that they collected. But different data had different numbers. But they found that it was more than 70 beats per 24 hours. So the first one said 32. This one says 70. So which one do we go with?
32 or 70. We'll find out. Because the jury is still out. So I did some mathematics. Hopefully I didn't make any mistake. So we always say that the normal height is between 60 to 100, yeah? Good. So I said, okay, let's take those averages. 60 per minute. If you multiply it by under 60 to get your hour, you get 3,600. And if you add 100, you get 6,000. So if you were to look at 1%, if it's only 1% that was the high problem, it's between 36 and 60 beats per hour. Now, that's very important because when I was going to my specialist schools, that's what I call them, the ECHO said mild relaxation abnormality or ECHO. Anything mild, I'm not too worried about it. And this is the diastolic component of it. ACE was increased at that time due to the blood pressure not being controlled. She had he had a repeat assessment and was complaining of palpitations. Cardiac tests were normal except for Holter. There's 2.6 VE run, 2.6 packs paroxysmal atrial complexes and VE run of 11 beats. Stress test was normal. That's very important because if the stress test is normal, there is no significant coronary artery disease because that can also be the issue. So the patient was looking for follow-up. Now, when we do follow-up on that, it's going to be to see, does this 2.6 become something else after that? That's where the follow-up is very important. Now, excessive supraventricular atriopic activity is something I want you guys to think about when you see your patients. When you get EKG done and you see one blip that does not fit in the whole dance, that is an atrial. Is it wide? Is ventricular? Is it small? It is atrial. And if there are few of them, do not overlook it, say go home. Because when you send the patient to go to a lab and they get an EKG, the doctor who will need the EKG is not seeing the patient and it's not going to get history. How do you say? To suspect it on ECG or Holter, what do you do about it? Depends on the frequency. How do you monitor it? We need more studies. We need more studies, and that is what we're waiting for. Okay? So before I close, just one or two more slides. I'm a stroke specialist. That big thing there is a life vessel disease. When you see that small thing there in the periventricular area, that's a small vessel disease. The treatment of small vessel disease is by treating the risk factors, cardiovascular, blood pressure, diabetes, and everything else. But when you treat for large vessel disease, is cardioembolic stroke, AFib will give you debilitating strokes. You don't see something small and call it AFib. No. This is large vessel disease and it's very debilitating. Okay, thank you. You see, what you did was right. You did your part. You referred to the cardiologist. It depends on the duration from when the cardiologist saw the patient and when the heart attack occurred. So usually, we would like to see patients in follow-up. If I see a patient and I discharge them back to you, that means I'm not worried. But if I see a patient, I will always bring them back. I brought patients back in 1 week. Blood pressure 180 over 100. And the person is spoken. I feel fine though. There's no headache, there's nothing. But the problem is not that. The problem is when you feel something, you're dead. I start them on something, bring them back in 3 days. I won't even do a stress test for them because stress tests, blood pressure will go up and they will collapse. So that's what I'm saying. You did your part. The cardiologist should have opted to bring the person back.
So I think that's what.
Doctors and dentists. And because we specialize in only working with doctors and dentists, we know how to considerably reduce, if not completely eliminate, your taxes using the legal, ethical loopholes available to us through the Canadian government. Now, imagine this allows you to live your life to its extent today while not having to worry about your future. You can make sure that you can live your life today, go on vacations with your family, pay for unexpected expenses that come up if your roof leaks. You don't have to worry about any of that, and at the same time, you have to not worry that your future is going to be in jeopardy, that your retirement is taken care of. You get to do all of this while paying the least amount of taxes. That's what we call a rich, fulfilling life. Hence, RFL Wealth. Our process is really simple. We meet with you for the first time for an introductory call to see if we're going to be a good fit. From there, our second meeting is called Quantifying Your Rich, Fulfilling Life. This meeting only has two objectives, and it's super simple. Where are you right now, and what are the goals that you're looking to achieve over the next 5, 10, 15, 20 years? Once we have those two things together, we can map out how it will work, and that is your financial life plan. This isn't just an investment projection that says, if you save X amount of money, you'll have this much available. No, this goes over each and every one of your goals, how you're going to achieve it, and how your retirement is going to look like. And how much money you're going to pay in taxes, or rather, how much money you're going to save in taxes. It's super simple. We're located right there in the back. We put up a weekly podcast only for physicians and dentists, where we answer all of your problems. We have a raffle actually going on right now, so if you sign up with us for our newsletters, we have an iPad that we're going to be giving away. Again, we're located right there in the back. My name is Usman Jamal. I'm the Director of Financial Planning for RFL Wealth. I have Francis here with me. He's one of our trusted financial planners, and I'd like to thank CANPAD for having me out here. Thank you very much.
And I'll tell you how this journey came to by. This is Olajimo Keseriki. We came into Canada some few years ago, and I saw the way we were paying so much taxes. And I was like, what is going on? How come you earn so much? For example, you're earning 500,000, and you're not careful. CRA will be taking about 200,000 from your income. Then the question is, who am I working for? So that gave me the urge to look at what are the things we have to do to get to the solution. My slide is down there. So my thing to make sure that you are being efficient and let your money work for you. So, and that is why we came by this. So, in as much as we are telling you what you need to put in place, we also educate you so that you are an informed consumer of what you're doing. Number one, you're working, whether you're incorporated or unincorporated, you need to protect yourself. Because remember what you're doing. If anything happens to you, what are you going to take home? Nothing. Because once you're incorporated, nobody cares for you. You cannot drive a car in Canada without insurance. If anything happens to the car, somebody come and take responsibility. But your life is not protected. That is why that is our first point. Make sure you're well protected. When you're well protected, then the income you're earning, what are the strategies you can put in place? Then you look at all the tax incentive measures, tax native measures that you can do. Canada has some things you can actually take advantage of, even up to the level of your children. But if you don't know, you don't know. And that is why we are here to talk to you that there are lots of things you can put in place. Even come to talk buying properties. Okay, this is just talking. So this is what Financial Group, our company. I'm not going to waste too much about that. We've been in business for so long, over 30 years. Now, this is all what we do. RESP, which is Registered Education Scholarship Plan for your children. Whatever you pay into that account, government meets up, 7,200 per child. So even if you have 5 children, they will pay you. But if you don't open the account, you're going to lose that amount. Nobody will going to tell you about it. Life insurance is the one I spoke about, that's the protection. Education, scholarship, even when they determine to go to maybe uni, some people send their kids outside. So there are other things you can do, and all this money stays invested. And whatever income you pay, you earn on it, because the children are on low income, low tax bracket. So at the end of the day, they can enjoy it without paying any taxes. You spread it over the course of their program. Then for young adults, TFSA, and when we say young adults, for the INGs that you're just coming in, you can enjoy all this. Your TFSA, that's the tax savings account. We even tell people, even if when you want to buy investment property, please maximize your TFSA. Whatever you use that money to, you don't pay capital gain on it. So instead of using your income to buy your rental properties, please use your TFSA money. FHSA money is the same thing. It's a very good tax incentive, but it's only for first-time home buyers. So if you have bought your home, it's no good for you. So you don't need to open that. So if you are planning on buying your home, we will do all this for you, and everything here is not what we do. Then for investment in TFSA, tax-efficient retirement planning, I asked the question when I started, where do you want to see yourself in 5 years, 10 years? Having worked for so many hours, earning so much income, when you are 60 and you are retired, what brings income home? Make sure you do it efficiently. Because by that time, you're not earning much, your tax bracket is lowered, but then you're enjoying income. And the insurance I spoke about, your insurance can also pay you income at that later years. So all these are what we talk about. We'll be happy to see you later. And this is not a one plan for all. Everybody is different. Your family dynamics is different. So wherever you are, we sit down with you and we design a plan for you. Tax efficient way, and you bring good money and your money works for you. Thank you so much. We'll be waiting to see you after. Thank you. Patient are you providing chronic disease management for? How many of those patients are you seeing for preventive health care? Because we don't want to treat when there's disease. We want to prevent, which is what we never had that opportunity to do in Nigeria while we're home. Now you get the chance to do this. So you're cutting back on the patient doctor scarcity in your community, and also you're reducing the work burden on yourself when you take on a clinical assistant who is an IMG, who already has medical knowledge. Don't go and take sorry, let me look around. Don't go and take those physician assistants that just went through Niagara College, and then you think that they will have the same knowledge as you. No, they don't. Okay, you have to If at the end of the day you see that you're going to be solving a problem in the community, when we help the IMGs to integrate into the health system, there's more than enough opportunity for everyone to have access to patients. There's no like, oh, I only have 1 million here, so I don't, or maybe, let's say 1,000 patients here. So I don't want more people to come in so we don't have to struggle for patients. There's nothing like that. There's too many patients in the community looking for a family doctor, not just any family doctor, but a good one. And we should give our IMGs the opportunities to get into the system and demonstrate what knowledge they have. And of course, they have opportunities to get trained. So finally, that's all I have to say. Dr. Natalia Odude.
There was this thing here. I was worried because I've got ADHD undiagnosed. So this is what's going to happen. So I was thinking I was going to fall off. So my slides will come up now. Airport, arriving in Canada. So was that an accident? Was that fate? Because actually, now they will tell you, I had issues with concentrating, but it became something else. And I'm not too much of a ladies' man, but I became a people person, and I follow that passion. And so that you can see that MBBS only 3, but there's actually more inside. And if you notice any ADHD traits, they are also invited. Anybody, you all have something to give. I think that's the message here. So whether you're the one that got degrees or not, you have something to give, and I have something to give. And I've got an IMG who has a lot to give. She sits in IMGs. So this is an IMG. So Nigeria, UK. UK for 18 years, Nigeria for about 6, and I met somebody before I went to UK. So that's the real story. So why do they matter? Rosemary has covered the statistics. You know the people that go to school. statistics, 2%, 3%. I don't know the number. All I know is somebody's here. I want to empower them. I don't care about the number, just come. I've met a few IMGs here. If I've met you before or spoken to you, you can just give me a show of hands, just to give me some encouragement. How? That's passion. It comes from the belly. It's not something to be boastful about, it's just who you are. So each person has something they have. So their story, then it becomes our story. Stories are very good, because that's part of community. I'll demonstrate this to those that don't know the community well in 2 seconds. What is needed, who is needed, making it happen. That's essentially what it is. Let's get it done, with everyone putting their hands together. So, you see, you have to renew your mind. Say amen. So community starts with one person. If I fall off, pick me up. It starts with one person, and then it grows. But when an ADHD person or undiagnosed tells you the take-home points at the beginning, it's because they're all over the place, where they calculated to give. Then you go, you come in, you grow, and you motivate the next person that's going to grow. So go, grow, and motivate. You can't stand still, like ADHD situation. So, you renew your mind. The things on that list, there are things that either you have it, self-centered, or someone is the perpetrator to you. Whichever one it is, recognizing it and trying to fix it. Bias, distrust, apathy, empathy fatigue, you're stressed. You can cause my own, let me just do my billing. Because I mean with MNG. Is she good? Can I take her or not? Those are the things we need to unwind. What are you really doing? So my dream, I was in hospital 5 days after arriving here for a week. That's the sad part. But I'm here today. I was ill. And I looked at Open Trafalgar. There was no black person walking around this place. I mean that not to be sectionalist. Fact. We want to change that. So, for those who are familiar with slogans like Black Lives Matter, it doesn't matter if you're just carrying placards. Your 7-year-old needs to see Dr. Rudy on TV, marching about the place, jumping. I'm a shy person, though, but when you follow your passion, I don't really, they're not intimidating me here. Nothing is happening. So, renew your mind. Now, if you look at that, we're all looking in. So look in, forget your building, forget your pay. Money will come. They'll sell you RSPP, PSP. Money will, it could be up to you, up to me, up to them, up to us here. But actually, it's irrelevant. So we are doing something. Does that make sense? So we remember take-home points already given at the beginning by an ex-ADHD, ADHD. The point is, you go, don't stand still. You grow, and you motivate someone else to grow. And that's it. Spirals. So once upon a time, that's Nigeria for you. If you don't know that, then you're not a real, that's the community, that's the signature. Once upon a time, time. I'm very aware of a young man who met a doctor in the early...
Okay. Silver nitrate, very easy. You buy the container and then you just do the cauterization. Once you do it, you see it goes all white and then it just shrinks almost immediately. So this is it's most of the time it gets smaller, but I've seen a baby that actually it turned into like a form of a cyst, and now baby's having like surgery. So if you have a silver nitrate, it's a very simple office procedure, and you can just do the cauterization in the clinic. Sometimes it's very big, you might not get it all in one day, you might need to repeat it very important also to note, when you're using the silver nitrate, always sort of clean, because you can leave like blackness in the skin, but you can reassure the parents that would get over the next few days. Okay, so silver nitrate in clinic, avoid at home care. What's this? And we see a lot of this. We put them out. It comes in waves. I'm seeing a lot of it recently. Okay, what do you want to do? To ask us what to do. Okay, And I just wanted to mention there's a site online, the Canada site, where you can see at 12 months, second dose given between 4 to 6 years. Both doses give a 95% lifelong protection, okay? Now, early vaccination, 6 to 12 months of age, travel to high-risk countries, exposure during a local outbreak. I'm not sure what you guys are saying in your clinic, but I'm seeing some parents come and say, see, we're going to Jamaica, we're giving the measles vaccines to those cases because they're traveling. Most of the cases we deal with travelers. So when parents come, the most important thing is for you to discuss with them that if the child has it, the child still needs the vaccine at 1 year, okay? When the child still needs the regular dose. So if you give a child at 8 months, you still need to give the 1 year vaccine. When the baby is 1 year, and you still need to give the 4 year vaccine, okay? So they still need those 2 doses. Very important. If you're canceling the mom, you know, you need to let them know they still need to come back for the one. Even if the child is 10 months old, they still need to come back for the 12-month vaccine and the 4 year vaccine. And so we don't give babies less than 6 months, mainly because the maternal-derived antibodies can interfere, and then the efficacy and safety is not being proven. I just put a bit about post-exposure prophylaxis. Some of you might see them in your clinic. And key message with measles, over vaccination when indicated. Stay alert for the outbreaks. There's also a site in Ontario where you can see where the cases have been, and they tell you what time the cases were there, okay? And educating the family on time about catch-up vaccine. So that's all for today. I hope
How many doses? Booster dose?
Yeah, so if the child, if they are unvaccinated, they get the immunoglobulin. Okay, if they are vaccinated, they get the MMR, okay? Within 72 hours of exposure. So that's the 2 things that we get here.
You know, with the outbreak now, what's your position on early vaccination for, you know, getting the second dose? Because I know in some other provinces, like in the east, in the west, the measles vaccination is actually 12 months and 18 months. But in Ontario, I see that it's 4 to 6 years. And because of, you know, the outbreak, the position for earlier second dose.
Thank you. So
Thank you. The baby not having enough breast milk is more common in first-time moms. And do we really have to do something about it? Like when they say, oh, the baby's not having enough, but they're gaining weight, and it's a first-time mother, she's a little anxious. Do we really have to do anything about that?
I'm trying to understand your question. So the baby is gaining weight?
Yes, it's the first time. Most of the time, I see first-time mothers complain about the baby's not having enough breast milk. But the baby's gaining weight and the baby's fine.
So they feel they are not producing enough?
They just feel they're not producing enough.
Okay. So it's reassurance. So in terms of things that mom can use, the urine output, okay? Urine output are reassured. How many pieces baby gets in a day? Mom tells me 5 to 6 pieces. Baby is alert, baby is well. So I tell mom, on your own part, that's what you see. On my own part, baby was seen today. This was the weight where we saw baby 3 weeks ago. You can see baby's weight today. Baby is gaining the adequate weight. Baby is gaining about 150 to 200 grams. Put the growth chart. When I see them the second time, I can see the progress. So sometimes it's mainly reassuring. Baby is growing well. Baby is not vomiting. You know, we assure mom on our own part, she can use urine output, the baby's alertness, and on my own part, so everything's going in the right direction. So it's mainly reassurance.
Thank you.
Thank you, ma'am, for the very informative lecture. My question is on GERD. So having confirmed the diagnosis, you mentioned using PTI, which we comfortably do in adults, but now we're knowing that if adults are on PTI for very long, you have to worry about magnesium levels and all that. Is that a concern in kids? And then how long do you normally, would you put them on the PPI for before trying to see whether they can get off it?
That's a very good question. And I think it's one of my slides. So, going back again, so if you just gastroesophageal reflux, baby is not settled, baby is not irritable, you don't need to start. So, for GERD, you put the D, so yes, if baby is not settling, you start the lactose or mucus. What I usually personally do, when I start the baby on it, I start on the lowest dose, and I give them for 10 to 14 days, okay? Because there's no point putting the other answer to your question is 6 to 8 weeks, the maximum we give it to them. But I usually give 10 to 14 days, and then I see the baby again after 7 to 10 days, or I even speak to the mom on the phone. If baby is not getting better, okay, maybe sometimes there's a bit of improvement, not 100% we may increase the dose. But the first thing I want to see is this helping this baby. Because sometimes the parents present the history, you know, I said good history, but it might even be poorly, but the way it's presented, the thing is that if it's not helping, you don't just give 6 to 8 weeks and say, bye-bye, come back in 6 to 8 weeks. So that's the first thing I usually do, that when parents come back and say, oh, the child is completely different, it's more settled, and then I give him the bottle 4 to 6 weeks. So it's a 6 to 8 week course, which is not usually associated with those side effects. Does that answer your question?
Thank you.
Thank you, Dr. Alaba.
Regarding breastfeeding, there's a little bit of a conflict compared to what I've learned on how to educate, especially new moms, on breastfeeding. Usually what I learned is that for parents who are willing to do or looking forward to breastfeed exclusively, that you tell them no bottles, no pacifiers, nothing else, just the breast. But I have a lot of patients coming from hospital and they are already told to express, even though the baby's feeding okay and gaining weight. Even when they see the nutritionist or the breastfeeding support groups, they're encouraged to express. Is that something that we should be talking to moms to do, to start to express and monitor the amount of feeds that the baby is having from bottles if there's no issue?
Okay, thank you very much. So the lactation, we now have a lot of lactation consultants. I never had a lactation consultant that came to Canada. I don't think we have them in the UK. I don't know, maybe the midwives just help them. But lactation consultants, most of them have been seen by lactation consultants, okay? And sometimes they are not latching on and we tell them that. I'm just guessing that. But yes, you are right. When you're breastfeeding, okay, we always encourage breastfeeding. And you can see even with the case of the first mom that I mentioned, breastfeeding is still the most important, but if mom's milk is not coming, okay, that's why I usually say to them, you don't want a baby who is dehydrated and ending up in hospital, okay? And always I tell the moms, breastfeed first, put the baby on the breast first before you put the top on, okay? So that's, so you are right, they should breastfeed. And also the formula and the pacifiers can confuse, so we say don't start pacifier early. Pacifiers have their own advantages too, but don't start in colors. I see children lose weight. If I can explain it, I'm not worried, okay? I had another child, the parents dropped one of the bottles. They stopped giving the child a nice bottle. And you know, they just, and we could see it in the chat. And they're like, oh my God, Dr. Alaba, I didn't know you pick it up. I dropped the last bottle and saw the weight come down. Okay, and we put it back and you see the weight go back up. So I think the history is very important. We can explain it. If you can't explain it, it might be a new thing. So it's very important to investigate based on what's going on.
Overweight? Do we worry about overweight?
So the child of overweight, so that's above the 97 cents. Now on those charts also there's a BMI chart, okay? There's a BMI chart on the chart. There's some clinics that will see children, there are not many of them. There's a dietitian, there's an endocrinologist. So if you're over the 97 centile and progressing above with the BMI, then ideally they should be referred. You can start first of all by talking about the 3 things: physical activity, non-sedentary lifestyle, and diet. Okay, so those 3 things are important. And then that's usually it's all. You have to also be sensitive in breaking that down for the parents, because it's a very I've seen many of my colleagues get parents lash out at them. So it's just saying, and that's why the growth chart is important. You're not just saying, oh, your child is fat. You're saying this is usually where children are. Baby B is slightly above this, and we want him on this side.
Everybody up. So I'm supposed to have been the first speaker, but I understand that the second speaker didn't show up. So that's what happens to me. Since I was born, I'm always pushed to go in. So I'm ready for it. Okay, so what I'm trying to do today as a stroke specialist and also as a cardiovascular specialist, I'm trying to marry them together. People always ask me, what is your specialist? I said, sir, if I start counting it, we may not be finishing today. So I wanted to bring up a topic that will be relevant to every family physician.
Doctor, because it's so realistic. But this is all coming, and in Canada, we're always a little slower to the game, and that's probably because we want to see what's happening everywhere else before we decide we want to do it. AI is really that field that talks about machines and making them smarter. And it's really a general term which allows computers to carry out human-like behaviors. That's all AI is. It's that it's a computer that allows it to carry out human-like behaviors. Then machine learning, you might hear that term, and that's a type of AI where now the machines don't have to be programmed. So before in computers you had to program an algorithm, but now the machines don't have to program because they self-learn, and they'll actually teach other machines. So AI will keep teaching AI. Deep learning is how it mimics a human brain so that it kind of learns AI in different areas. And then it goes through natural language processing. So when you go to Google and you enter something in the search bar and it gives you suggestions, that's natural language processing. When you go into ChatGPT and you ask your questions, that's based on these neural networks, that's based on these large language models. You realize it. But in medicine, we're not really using it in the community as much. So AI Scribe is really speech-to-text technology. So dictations, how many of you have used a dictaphone? Or for dictations? Okay, perfect. So AI is not a transcription service, it's not a dictation service. So it uses that voice to text and then reorganizes it into a note that's complete. Could be like a SOAP note or a consult note. It could be an insurance form. It could be any template that you could put into the AI. So it's kind of like, I always say, it's like dictation on steroids. It's got that extra piece to it. And really, that's what's taken off right now. So we did a study. So the Ontario government funded us, along with two other organizations, ECE and we, to look at AI evidence-based, right? So when we look at a drug, when we look at anything, we don't just start using it. We have to look at studies, we have to look at the evidence, we have to decide, is it going to make a difference? Is it worth where I put my money? What are the stuff that I need to worry about, right? So it's the same kind of study that was done for AI Scribe, and it was done in a lab with time motion studies where standardized patients and kind of watching and see, and 150 clinics in the community. That was a good cross-section. Different languages, different accents, different demographics, different patient types, to see, is this actually a technology that's going to work for all, or is it just a technology that works for some? And so the studies from this that came out of it is that, yes, it did reduce the burden, only for documentation right now. So if you're really good at typing, and you're really good at documenting, and you're good at using your EMR, this may not help you much. But if you're not so great at all of that, then the AI is great for the documentation, the report writing, the consult. So it might not be for everyone. It was a 4-hour savings per week. You're probably like, 4 hours a week, that's nothing. But honestly, 4 hours a week means I don't have to work Sunday nights, right? So, but for some physicians, it actually was 4 hours a day. So it really depends on how your practice is and how you use it and whether it actually helps you. And interestingly, female doctors have more benefit from AI than male doctors. So now that we know AI works, it's not like some areas, then people started using it. And it's actually, for once, we're starting to talk about that joy in medicine again, right? Like all that paperwork, that's not why any of us went into medical school. I don't know about you, but I didn't go into medicine to write to do all those forms and referrals and have them rejected and resent out. Like that's not why I went to med school. And so what we're finding with AI Scribe is the reason most of us, and not all of us, went into med school was to actually have that interaction with patients, right? It's that listening to the story, sitting down and really understanding. And this is a technology that allows you to do that because you can start making eye-to-eye contact again. And you don't have to be like you're back and the rooms aren't set up for your EMRs and you're typing away and the patients don't even know if you're listening and you're back and forth. That actually gets a lot better. And that cognitive load gets better. The fact that you have to remember and think everything, it's being captured in an AI. So there's a lot of positives there to look at. So I'm gonna but I wanna highlight a little bit of what you need to worry about AI, right? Like it sounds great, but there's other things that you need to worry about. So I'm gonna take you through Maria's day, right? It's kind of like an AI clinic. So some of it you can use now, it's already out there, but the majority of it is just on the cusp. It's just about to come mainstream. So imagine if you start your day at 8 o'clock And you're kind of sitting there, you've got all your labs, all your reports are coming in, you've got your day sheet, all these patients are coming in, and now you're just like, oh yeah, did I get that report back? What was the lab? Because they're gonna ask me, and then you're searching and you realize you're missing something. So imagine if you have an AI that actually knows all that, has mined your charts and have given you summaries of the patients coming in and told you what's outstanding and what you should do, so you don't have to do it yourself. The other thing is about kind of that daily grind, the paperwork piece that I talked about, that gets better. The last thing is, what about that, the second two things is, what about that patient interaction, right? So I'll give you an example of that middle diagram, right? So you've got a mom, 3 children, comes a lot, worried about the kids, maybe it's cold, maybe they're sick, they're not feeling well, they're not sleeping well, many, many appointments. So in those appointments, you could have an AI that says, you know, this matches a certain diagnosis. Have you thought of ordering these, right? This is the AI that's coming up. Or it could be like, okay, this child's come in 6 times for antibiotics for a ear problem in the last year. Like maybe this is something that needs to be flagged because you're not seeing how often they come because different doctors are seeing them in the clinic. So could that help you a little bit? Then the third thing is, what if you have a patient that comes in, Mark, who's the last one there, he's got hypertension, and his blood pressure's dropping down. But you could actually have him check his blood pressure at home. You could have that information brought into your EMR, and then you could have AI kind of do some triaging, which helps then with your nurses to figure out when they should pull in patients and when they shouldn't. So none of this is mainstream yet, except for AI Scribe, but it's all coming, and you're going to hear about that. You're going to read about, oh, this is cool, because it's everywhere. But AI is not without bias, and this is the part that I want to talk to you about today, is that, okay, now let's look at Maria's day again, right? So she's come in, and now you have this AI that summarized everything for you, right? Told you the gaps, told you what you've forgotten. But is the AI right? Like, do you know how it's decided that? And now, are we liable if the AI is wrong? So right now, if you use anything, you take on that responsibility yourself, because even the CMPA and the CPSO, they haven't even figured out themselves how they're going to adjust that liability piece, and how they're going to be like, okay, if you use this technology, what happens? The other thing is bias. So Maria comes in, she comes in many times. She has 3 children, there's always a different piece with them. And so, you know, eventually, like the words of anxiety comes into the chart. You know, the mom is worried, there's anxiety. And Maria's getting labeled because now that AI picks up the words in that chart and then just refocus AI is thinking. So you have to be careful of bias. And the last one is, so Mark being a person of color, his blood pressure, his kidney problems, his diabetes, it's a different piece if he was Caucasian versus South Asian versus Black. There are different ways of looking at it, and you have to identify that. But does the AI know that? And that's really important because we all know from the studies that are out there that it doesn't always match the population of patients that we see. And we sit there, we adjust for that. But if AI may not. So these are kind of things you have to think about is like, how are they doing this? There was actually, this was a really interesting study, which I always like to show bias, where they looked at these platforms of AI that develop pictures, and they asked 5 platforms, show me a face of a doctor in the US, show me a physician in the US, show me a photo of a doctor in the US, and show me a photo of a physician in the US. And they generated over 1,000 pictures. Of the pictures, when they compared it,
so, as traditionalists, we have to call up some integrities here to come in. So the LOC members, Dr. Rosemary, Dr. Rumed, Dr. Thank you everyone. We really appreciate you for being here. We are having our last talk right now. after this will be done. Thank you for your patience, and we really hope that you learn a lot from this conference. So without further ado, we want to call on the Metro guys to come over. They're going to talk about billing in Ontario. This is where the tire or the rubber hits the road. They're going to talk about how you make money, how to bill rightly, how to bill correctly, so that you not lose money.
This is my second time up on the stage. I'm feeling a lot less nervous, so great to be here, great to be back. I'm not going to take up too much of your time today. I know you're in a rush to go home, so I'm going to have a very brief presentation for you this afternoon. We're going to be talking a little bit about OHIP billing. We're going to be explaining it, not in too much detail. We're not going to bore you to death with the codes. We're just going to give you some tips and tricks, some common errors that you could face as a physician, and ways to maximize your billing. So let's go ahead and get started. Everyone knows about OHIP billing if you're a family physician and if you're practicing in Ontario. So whether you're a veteran and you've been doing this for a long time, or if you're brand new and you're just starting out, it depends on your situation, but everyone faces challenges with OHIP billing. And so what we're going to do today is we're going to talk a little bit about that. We're also going to cover two other areas. We're going to talk about primary care models in Ontario. We're going to focus on three big ones. And we're also going to talk about how billing agents may be able to maximize your revenue. All right, so let's get started with the primary care models. In Ontario, we have a variety of primary care models. Today's presentation, we're going to focus on three big ones. We have the Family Health Group, the Family Health Organization, and the Comprehensive Care Model, also known more fluently or more familiarly as the FHG, the FHO, and the CCM model. So at the end of my talk, you're going to understand a little bit more about these three models, how they work, the pros and cons, and maybe start thinking a little bit about what primary care model works best for you as a physician. Okay, so let's get started with the first one. We have the FHG group, also known as the Family Health Group. This is a fee-for-service model, and it has some additional perks. So in an FHG, you're going to be getting paid for every service that you provide, but you also get extra incentives for things like after-hours care and group collaboration. In order to be a part of an FHG, you need to have at least 3 physicians working together, and these 3 physicians come together. It fosters teamwork, and it also helps with shared responsibility as well as collaboration. So what are the pros of this FHG group? We have flexibility.
Sorry, please, can we please?
An FHG, you need to have 3 physicians to qualify for this. You guys are going to work together. It's going to be teamwork and collaborative, and as well as that, you have shared responsibility. What are the pros of an FHG? We have flexibility. So doctors earn more for after-hours work, and that group structure, it reduces individual stress, and that sharing of the workload reduces your overwork and extra time spent in the clinic. Patients also benefit because they have that extended care and extended hours. There are downsides though. So with an FHG, the downside is that you do not have access to allied health professionals, such as dietitians or counselors. So you have to really rely on your own selves to provide that care. And as a result, if your patients need that additional care, they may have to go outside to look for that. In addition, what you need to do as an FHG physician is you need to see a lot of patients, and you can't spend a large amount of time seeing these patients. So if you have a patient which has a very complex case, you cannot spend that much time, as much time as you would like to spend, because you're in a hurry to get through your patient roster, so you're trying to rush through, and some patients need more time than others. So that's another drawback of the FHG. Think about how you're leveraging those and see where you're going with your roster. Let's talk about the next one, We have the FHO. In an FHO, or a Family Health Organization, this is a blended capitation model. This means that you get a base payment for every enrolled patient, and on top of that, fee for service for certain procedures and bonuses that are tied to your patient's enrollment. And this is designed to reward comprehensive care and patient loyalty. So the FHO also comes with pros and cons, just like every other primary care model. The pros here are very significant though. So for example, you get steady, predictable income from capitation. And your patient enjoys those after hours that are longer, and they have access to more support. patient that's rostered to you, that patient only can come and see you. That patient shouldn't be going to a walk-in clinic or going elsewhere to any other doctor. So that limits your patient's access to care. They can only come and see you as their patient doctor. And as for physicians, the other con is that your workload can go up and down based on the number of patients in your roster. So for example, if you start rostering large amounts of patients, your workload is going to start increasing, and that workload increase can lead to stress. So you have another con in that area as well. So if you're in an FHO, make sure you're tracking your patient enrollment, because that patient enrollment is directly tied to how much money you'll be making. All right, let's move on to the third primary care model that we're talking about today. That is your comprehensive care model, or the CCM. So what is a CCM exactly? A CCM is perfect for solo physicians. So if you're a solo physician and you're by yourself, this is the best fit for you. It's an enhanced fee-for-service model with incentives for patient enrollment and preventative care. It's very straightforward and it's extremely rewarding if you focus on comprehensive care. As I mentioned, every primary care model has a downside. The downside of a CCM is similar to an FHG, which means you don't have access to those allied health professionals, such as your dietitians or your counselors. So if your patients need those, they have to go elsewhere to look for those services. So if you're a solo practitioner, the CCM model could be a great fit, but you'll have to stay on top of those preventative care bonuses to maximize your revenue. All right, so I talked a lot about those pros and cons. On the screen behind me is a table outlining everything that I went through. So we have the pros and the cons that I just mentioned for FHGs, FHOs, and CCMs. You can look at it real quick. I'll do a quick recap as well in case you missed out. So for the FHGs, your pros are that you earn extra payment for after-hours care and for preventative care. The teamwork aspect helps you work together with the other doctors in your group. However, the cons are, again, the lack of access to your allied health professionals, and you're focusing on patient volume rather than the quality of patient care, so you're not spending as much time as you might like to in those complex cases. Like taking a look at the flows, the straight up, the best kind of pro of this one is that you have your pay is based on your signups and your extra fees. You get longer office hours, you get an additional phone line to help you. However, your con, the big one, is that your patient has to come to you every time they need to see a doctor. You may have extra work, you may have extra stress, so that all determines how much work you're going to be doing. And finally, with the CCM, again, extra money for doctors who focus on complete patient care. However, no access to allied health professionals, which means your patients are going to have to go elsewhere if they're looking for extra services. So what's the key takeaway here after looking at the pros and cons? Each model has its trade-offs. The best one for you depends on three things: your practice style, your patient base, and how much you value predictable income versus flexibility. So those are the three things you should be thinking about when you choose which primary care model works best for you. So what I'd like you to do now, as I go through the rest of my presentation, is take a moment to reflect and think which of these models best aligns to your goals and where you see yourself in the future. All right, we're going to switch gears. We're done talking about primary care models. We're going to jump into the schedule of benefits now. So let's talk about the schedule of benefits. It got a huge update in April 2025, just 2 months ago, and this is really exciting news for your wallet. Let's talk about what happened. So, a couple of things happened. From April 2023 to March 2024, there was a 2.8% increase across the board, which you saw if you were looking in your November 2024 RA. So if you haven't looked at your November 2024 RA, now's the time to go back, pull it up, and see what it looks like, because you should have received that extra 2.8%. On top of that, there was a temporary 9.95% increase from January to March, bringing that total increase up to 13%. Again, go back and check your RA of November 2024 to make sure it's there. And now, starting in April of this year, everything has changed as well. There's a new compensation structure, which has been it's turned more into a relativity-based model. What does that mean? That means 25% of the increase is across the board and 75% is specialty specific. That means it's based on the factors of your specialty. Why have they done this? They have done this to make sure that compensation is fairer and also to support the sustainability of primary care in Ontario. So if you haven't looked at your RA, now's the time to go back and see how that has impacted you. All right, we're going to switch gears again. We're talking now about overcoming billing challenges. I know that OHIP billing may sound simple in theory, but there are small, reoccurring mistakes that you can make, and this can cost you thousands of dollars in additional revenue on a yearly basis. We're going to cover some of those top errors to see what they are, and these are errors that we've collected from real physicians in real practices, so this could be one of your errors as well. So there's 4 on the board. There's many more, but I pulled the top 4. These are the most common ones. Number 1, and this is the one that we see the most predominantly, when you bill the code for the wrong model. So for example, you're an FHG doctor and you bill a claim or a code for an FHO model. And so immediately what happens is that leads to a rejected claim, and then you miss your bonus, and then you have to resubmit, and that resubmission takes time, etc., etc. And as you can see, it delays the process of you getting your money. Then we have shadow billing. So for FHO doctors, shadow billing errors are a big issue. Shadow bills are those that track your services to make sure you get your capitation payments. Number 3, and this is another big one, missed preventative care payments or bonuses. If you forget to bill your screening codes, if you forget to track your patients, if you forget to contact them, this can all cost you significant bonus income. And lastly, if you're an FHO doctor, when your patients go to other walk-in clinics, you need to know when to de-roster your patients. If you don't de-roster your patients in time, guess what? OHIP comes back and can take away your additional payments and your additional bonus. So that is something very important as well. All right, so those were some errors. Now we're going to jump very quickly into ways to optimize your OHIP billing. So there are 4 main ways on the board. I'm not going to get into it in detail. Take a picture of the slide in case you want to refer back to it later. So, number 1, and the most important and most common one, is billing with the wrong code. We have 2 types of codes. We have A003 and we have A007. If you uncomplex code, you need to make sure you're billing A003. That gives you extra payment for the complex nature of the case. It pays more, so you need to make sure you're paying the right code. Number 2, missing your premium. So for example, your travel codes such as B990 or B991, or the time-based codes such as E83 and E84, both of these types of codes are very quick revenue boosters, and these are great for after hours and for holiday visits. So please make sure you're billing those. Finally, we have the mental health combos. So when you're doing a mental health consultation, make sure you bill the combos. You have the A195 with K07 or K005 to bill for both counseling and extended mental.
Now, in our group, we stick to age less than the official age of menopause. Official age of menopause is 51. So if you're over 51, there will be that reluctance to want to transfer an embryo into you. Imagine someone is 60 and you transfer an embryo to a 60-year-old. By the time the child is celebrating her 18th birthday, the mom is already 78. And who's going to be doing the child pickup, who's going to be doing changing the diaper and all that? And also, if you look at the generation of parents that will surround the mom, most of them have their kids already getting married. So it may be something of abnormal growth for those babies. So you have to look at the whole context. What is our situation? What's our financial might? What's our 50s? You have a higher rate of stroke. But you will even have mini strokes. right? Stroke, cardiac disease, heart disease, renal impairment. So there's a lot that goes into it. But if you are fit, there is no medical problem, then you have to constitute an ethical board and a multidisciplinary setting to determine whether it is safe to transfer embryo into such an elderly patient. So I don't mean to say that anyone over 51 is elderly, don't get me wrong, because I know there are very, very fit and healthy 54, 55-year-olds. But you have to individualize the cases. Make sure that this particular 55-year-old is strong enough to get pregnant.
This question is that who
He does want to ask.
Thank you very much. That's my bibliograph from Ijava. So my question is really, if you have actually had your eggs frozen, not eggs actually, how viable embryos frozen in say another jurisdiction, say in Europe or America, what are the legal implications if somebody wanted to transport that to where they live? And would you actually recommend something like that? Or would you say, go back to where you did that and everything works?
Yeah, that's also a very good question. We get it a lot. We have a number of people who have completed IVF cycles in Lagos, IVF cycle in Ontario, and they want to repatriate their reproductive materials from those jurisdictions back into here. There's really no limit. It's your embryo, you can do whatever you like with it. In fact, there are some courier companies who specialize in transferring human gametes from one jurisdiction to another. So there is nothing stopping anyone who have reproductive material in a particular jurisdiction. They freeze, they have to survive in thaw, and then there has to be fertilization when you inject the sperm or when you just do conventional IVF. But if you're freezing an embryo, you've already cleared several hurdles. And then if you have tested those embryos and you're sure there is no Down syndrome, no Edwards syndrome, no Barthel syndrome, even sickle cell disease, you've screened the embryo and you're sure the embryo is top notch, your chances of conception is extremely high, as opposed to just freezing just the eggs.
Thank you. To get where I am. So it's important for you, if you want to make money in medicine, there is the business of medicine. There is the medicine of medicine where you go to get all the pills, but there's also the business of making the money in medicine. When I came from Nigeria at the age of 23 to Amsterdam, I knew nothing about business. But the tough road forward taught me everything. We had to do MBA to know that what my mother and my father were teaching me was right. So when you get those degrees, it reinforces your ability to make money. So we want to make money, and that's why we opened up Eastside. Eastside has got specialists. I'm one of them. The other doctor was supposed to be here, an endocrinologist, but she wasn't able to make it. We have other doctors with us. Now, the reason why I'm giving this talk is because Eastside is one of the sponsors. The people who are supposed to talk don't want to talk. So they said, go back up there and talk for Eastside. I said, okay, I'll do that. Now, that's me there. Those are all the papers that I tried to pick up along the way. But because I'm an internal medicine specialist, when I see a patient, I don't see them because of only their heart. I see them from here to there. Their stroke can come in, the cardiac can come in. So at the end of the day, we do a comprehensive medical assessment at the site. We do have family doctors as well, but we do have a hypertension clinic, which most GPs refer to us because everybody has hypertension. And remember about this? Yeah, it's all about that too. But you must also look after the patient. The money comes after that. Once you do a good job, they will keep giving you very good reviews. Not that we have good reviews on our website, so don't worry. Because I trained in neurology, I did not graduate from neurology. I went to stroke instead. I was a registrar in neurology in Ireland, so I didn't waste all that. That's why I see some neurological cases. Okay? But because I have a degree in stroke, I do stroke medicine. I came to Canada purely to start the stroke service in Sydney and Halifax. I upgraded them. But when I finished, I love the country so much. Tests so that we can match the patient's symptoms with what we're seeing on the test. We also, because we do have blood pressure, we take care of our own ambulatory monitors. We do our own echoes. We do our own exercise stress test. We do our own photos right there in the same building. Now, we have very short wait times. Because of the degrees that are involved, you can see all that. That's all we do. And most of it is because cardiac is related to cardiovascular, is related to stroke. She is involved in endocrinology. So when you see herself and you have high risk factors, you'll be directed to see the cardiovascular team as well. She handles all of that, and we also do weight management. Well, because we've been doing not so badly, we made some small money. So we had to expand the place. So we have a new 5,000 square feet building beside this side. We are going to call it West Side. So that they can be, you know. So the idea is it's a 20-room medical complex. We're hoping to get in family doctors. We're hoping for X-ray, ultrasound, physio. And I'm coming to that. So at the end of the day, we are hoping that we can build something for Nigerians by Nigerians in the same place. Okay? Now, Hamilton area is very populated, so the number of patients are waiting. Our waiting list is long, 4 to at least 3 doctors. Okay? So the doctor we have right now is full, and we need to get other family doctors. We are located in a very high density area, and we have car park. Okay. When we come to the last slide there, we have been able to help one Nigerian pass her exam. That's the only Nigerian we got. That was 2 years ago. She's passed the exam. She's now about to enter into the residency program. That's a very good thing. Please. We have helped an Indian. Right now we have 2 people here. Are they still here, Captain? Oh, you're here. Now, we have these 2. You are from Brazil.
I'm from Mexico.
Good. And they have been working with us now for
about 4 months.
About a year.
Good. And they're both very, very exams. Now, the reason why I want you to know this, I left Nigeria at the age of 23. 2-3. And I don't see color. What I see is professionalism. If you're good, if you're a doctor, because I went through hell as well to find my way. So when I say doctor, it doesn't matter where you're coming from, we will give you a leg up. And we are hoping that this will be our next 2 to enter into the program. Now, why did I bring them up? Thank you. I brought them up to because I'm so happy to hear what's going on here today. This is the first time. This is the first time I'm being in a room full of this number of Nigerians since the age of 23. I was telling the president how impressed I am, because it means the country I left. When I came to Canada, I came as a stroke specialist. When I told them I was leaving Nova Scotia, they said, we know you're a specialist, but you must do the exam. I didn't know anybody. I didn't know any Nigerian. Read my books by myself, but only a Ghanaian called me back and said, come. No, those books you're reading are for Europe. Those are not helpful in Canada. If not for that Ghanaian, I would have passed the exam the first time. Now, it's one thing to do exam. Exam is not a training, it's an exam. In Ireland, we do something called the CCST, Certificate of Completion of Specialist Training. That is what you do to become a specialist. Passing the exam just makes you a holder of the paper. So, for me to leave Ireland and come to Canada after a CCST, means I'm willing to challenge everything out there. You must have faith in yourself, the IMGs. You do. You are doctors. You are very good. You're smart. But you need the breaks in between to be able to make it. And what we intend to do at this site, in the new complex, we hope to have Nigerian, non-Nigerian, everybody, IMGs, non-IMGs, doctors specifically, because when you want to take in people as physician assistants, you need the doctors who will be able to guide them, who they will see patients for. Also, these people need money to maintain themselves in Canada. It's not easy. So what I'm asking for here today is, this side is sponsoring part of this today, because we are Nigerians too. And we believe that if we get more doctors into this new complex, we should be able to provide more IMGs, pathways. Thank you very much.
Thank you so much, Rob. Thank you so much. Thank you so much for that wonderful presentation. So my question was regarding whether Rosen has actually been integrated with any of the EMRs. We've got quite a few in Canada. It would really be, nice to know that, it's good to go, ready to go.
Yeah, absolutely, good question. So we support effectively all the EMRs in Canada and the US. We have Juno, Oscar Pro as well. Everything is supported. So Rosen, you just need to give Rosen yourself a receptionist account, the way a receptionist have one today, and she'll take the actions in the EMR directly. So you literally don't have to do anything, just the patients getting booked automatically. Yeah. It's very cheap. It's like 1/5 of the cost of a human agent, and you don't have to pay, taxes or anything. You have to take leave of work.
So 1/5 of the annual salary or 1/5 of the monthly?
Effectively the same, right? If you do annual monthly. But basically you are spending easily 1/5 of what you spend for a minimum wage employee who is attending to the phones for you. So it's really, really cost effective, and it's going to do even more because Rosen will work after hours.
So it's just, I didn't have time to do my slides, so just one slide only. And the hope is able to summarize what CANPAD is all about. Are we good? We come to the end, For the exhibitors, I know you're still waiting. I am very cognizant of it. So we will. Sammy's Progress Group, MRX, and they are the ones left. So I know we'll create that time for you to speak to us. Don't worry. So, I'm going to do a few things, and I'm going to skip some. First, I want to thank you all for coming. This is the first time in the history of CANPAD that we're having a regional event like this. In the 23 years of CANPAD. I have to repeat that again, this is the first time. To have this number of participants, you people made it, a success. Thank you so much for coming. And we hope that this is going to be an annual event. They're already planning for next year to have a bigger hall, for us to be here. Now, CANPAD was founded more than 20 years ago by our founding fathers. And, okay, so this is an old slide. It wasn't what I had in mind. But basically, especially for the IMGs and for those from the UK, we've been here for 3 months. Like, what is CANPAD? What do you guys do? Who are you, If you're from the UK, it is similar to Mansang. If you're from the US, it is similar to Ampar. We also have in Germany also. Okay, can we just listen briefly, please? I know we're all excited to see one another, but let's get this ball rolling so that we all leave this place, in time. So what we try to do is to create an avenue for Nigerian doctors, as we can see, for us to network, to collaborate with one another, for us to support one another. We have the numbers, we have the brains, so to speak, we have the determination, so we should be able to come together as a group, right, to make things happen. That is basically what CANPAD is. And to also to change our community and our society also, irrespective of where you are. So, CANPAD, we have various programs, right? But I want to quickly jump to something that is taking place on July 31st this year. We have an annual event every year. How many of us have ever been to a CANPAD annual event? How many? Very few. Don't want to miss an annual CANPAD event. You see what you see here? Multiply it by 6. Alright? Whatever you see here now, multiply it by 6. It's a melting point of Nigerian families. So your kids are not here. Your kids are allowed to come. There's a program for anybody that is from day 1 to 18 years old. I'm serious. We have childminders that look after your kids. We have youth programs. We have picnics. We have CME events also, accredited CME events. They are working on it right now. Some of us have joined the CANPAD group. You're going to be seeing a lot of flyers reminding us to please come for the event. It's taking place in Edmonton from July 31st to August 4th. That's a long weekend. Go to the CANPAD website. You see the hotel reservations and the programs too. Please join. If you are a working physician, I think the annual fee is $550. If you are an IMG, the annual fee is $50. I don't know. But, you know, but for us, the Man City fan, we want 4 in the row, so we are okay, you know, no hurry, next year we'll get there. But, you know, there is sports events, there is picnic, there's a whole lot of programs we have. I don't want to waste my time take all the time talking about it. But the sponsors also have spoken to them. It's an opportunity for you to actually come to a place where you see what you see right now, but 5 times this number. It's very huge. So please try and be there. Now we have the ladies forum. It's a female physicians forum where the ladies they collaborate. They're actually having an outreach. Rosemary, when is the outreach? In Montreal.
June 18th.
Yeah, so the ladies, female physicians, they just got from a year ago. They're having an outreach with wellness meeting June 8th in Montreal. Those of you who don't speak French, in Montreal. Doesn't mean you say Toronto, it's not Toronto, it's Toronto. So, and it's not Saskatchewan, it's Saskatchewan. So anyway, so they are meeting in Montreal. So the ladies are meeting, and we also have an advocacy group also, which was just a committee. So we have a lot of discrimination, medical legal issues that affect doctors and all that. So this group was formed recently to tackle that, you know, and we have lawyers involved. We have mentorship and observership program. This is where I'm going to go to very, very soon, where people can meet and help people with observership. There's an IMG resource group. An IMG resource group is a WhatsApp group, where especially for an IMG, you put your name in there, looking for observership, we're able to match you hopefully with somebody. We're trying, it's very new, 1 year old, but we're trying to make that interaction happen between working physicians as well as IMGs. And we have provincial leadership across the country. We have leaders in every province, from BC to Alberta to Saskatchewan to Manitoba to Nova Scotia. Everywhere CANPAD is covered. I thought people would clap for them. It's not just CANPAD, it's Nigerians. Basically, we are well represented everywhere. We have to use our numbers to create a change in Canada. And it starts like this. All the presenters here, they are all Nigerians. Not that we're being discriminatory, we're just trying to show that, listen, we have the specialists, we have the expertise, we have it here in Canada. We have to start promoting ourselves. We have to start coming to the front to say we are here. And when the government knows that we have this sort of collaborative network, we become a force to reckon with. Not to do something bad, but to encourage change, to encourage things to be done differently, to take care of. There are a lot of things going on in terms of discrimination and all that, but that is a discussion for a different day. Today is just about us coming together. And also, we have been exhibitors. So many of us here been to the CANPAD Roadshow, not CANPAD Roadshow, to shows and be exhibitors like those guys. The whole idea is to meet with you, is to meet with Nigerians, is to register them, is for them to know that, listen, we are here for you. We're here for you to come and be a member. We're here to listen to you. We are here to help you to move, to get integrated into the healthcare system. That, in summary, is basically where I'm going to. And it has to do with the OSISCO program, which you've heard Dr. Rosemary as well as Dr. Nathan talk about. We have to make that change today. We already have a collaboration with OSISCO. They are waiting for us, CANPAD, to send us the names of those people who are willing to take on IMGs, and also the IMGs who want to be part of that program. So right now, this moment, we're going to have a paper, on every table. We are not going to be in a hurry. By the way, my name is Itwa. Itwa in a don't language, I'm not in a hurry. So I'm not rushing anywhere. I'm serious. So I'm very patient. So we're going to be right here. You're going to write your name, and you're going to indicate if you're an IMG or a physician. By putting your name there, we already have a database if you register. We just want to know if you are willing to be part of the Cisco program. Basically, if you're an IMG, are you willing to be marked in Nigerian, right, to do the clinical assistance stuff that we're talking about? And if you're a physician, are you willing to accept somebody in your practice, which I hope everybody will, after what nature has said? If you don't, now you serve you know? So, are you willing to accept somebody, you know, to come in and do help the person to get integrated into the system? So, just write your name, and please just write IMG if you're an IMG. If you're a practicing physician, just put physician, all right? If you know you registered for this program with the QR code, we will have your name on our database. So we're able to track you down, we have your phone number, email and all that, just to save time. But if you know you did not register, all right, you can write your phone number down. We have 3 minutes to do that. And I am very patient, we are waiting. Please do it. It's very crucial because we're going to have to take these names to Cisco, contact you, and then move on to create a database, which we hope to expand in July when we go to the Ed weekend. So please, let's do that very quickly. Write your name. If you are IMG, just put IMG there. If you are a physician, just put physician. If you register for this conference on the website, you don't have to put your phone number and stuff. We have everything already, but if you've been absorbing people, you know, into their clinics. Okay. I won't say thank you because the number is not a lot. It's almost like a 4-to-1 or 5-to-1. Maybe you didn't hear me. How many physicians, after what Dr. Henry said, Dr. Nathan said, are willing to absorb people as clinical assistants? Just put up your hands. I'm not saying that, you know, thank you. We'll start with any number. We're going to expand it when we get to everything, but we have to start somewhere. Like Dr. Adekonde said, you know, it takes a sperm and an egg to create a human being. So we'll start small and then we'll grow later on. It takes a seed to create a forest. No matter how small it is, we are starting this journey of helping our IMG colleagues to get into the system in Canada. And if you need help in this province, you all know your provincial reps. That's why they stood up. So we have Dr. already, please stand up. If you need help in Ontario, he's guilty as charged. And then you also have Nathan now in terms of the Cisco program. Okay, Wallet is also a very powerful man in Markham area. Okay, Dr. Rosemary, we all know her. She's a rep also. Dr. Yorinde has left. Dr. Ayor is not here. We have Dr. Ruben right there. She's based in London, Ontario. So he will also assist you too. So please, are we good with the list? The exhibitors will get ready. You're going to come up very soon.
How's everybody doing? It's a beautiful event that's been put on for us today. I just want to say thank you for inviting us to attend. So if you don't know me, I know some familiar faces in the audience, but my name's Jonathan. I work as the Business Development Manager for the Ontario Pain Clinics as well as Sammy's Clinics and Pharmacies. We have 5 now Nigerian doctors who are working with us and a variety of different Nigerian PAs that also work for us, but we are expanding at a very rapid pace. We have different opportunities depending on what you'd like to specialize in, as well as what city you'd like to live in, etc. And we can kind of tailor the experience back to you. We offer a one-stop shop when it comes to handling your practice. So we do marketing, we do management, as well as we handle your billing and a few other things so that it allows you to just focus on your practice. For the Ontario Pain Clinic side, we help physicians, family doctors who are practicing deal with chronic pain patients. So those are patients who are experiencing chronic pain for 3 to 6 months, or longer who are having a hard time finding anything that is working. We do interventional medicine, we do medication management, etc. So we have a booth set up in the back. We're looking for IMGs who would like to have a spot at one of our clinics, as well as family practitioners who are looking to expand their practice, maybe at a new location. We're offering very, very good incentives. I'm not sure if you guys know Dr. Soli or Dr. Babatandi or Dr. Bakari. They all work for our corporation across Ontario, some in Niagara, Dr. Oakley in Hamilton. But we're growing at an extremely rapid pace, and we can provide you with a great place to plant your roots and grow, and we'd love to be a part of that. But I just wanted to say thank you for having us out today. If you have any questions, please stop by the booth at the back. I'd love to have a chat with you. Thank you.
We are at the end of the convention, and I understand a lot of people have things to do, and I just want to grab your attention just for a few minutes to talk to you a little bit about what we do. With the help of some... Hello? Perfect. With the help of some friends in the room, I just wanted to say, and knows most of your financial and taxation needs. Why is that important? As I'm talking to more and more of you in the room, I realize we have something in common. And I know what you're thinking. Maybe he's part Nigerian. Managing family wealth and also transitioning wealth internationally. I know there was a presentation here where we talked about mobile fertility. We don't offer that, but we have mobile services, so we're very closely related. One of the aspects that we do, we're actually from a global perspective. So we have offices from a national and an international perspective. Being in 3 continents, it gives us a really good opportunity to understand clients, understand their backgrounds. For example, one of our clients came recently. Yeah.
Please, kindly pay attention, please. Give us a few minutes, please.
As I was mentioning, we're able to understand clients from a national and international perspective. I'm a war refugee from Albania, and I immigrated in this country, and I learned about what it means to be an immigrant, and not only operating, but also competing in this country, which is quite challenging. So I applaud all of you for making that decision. And one of the things that we have realized is that there's a lot of complications dealing from a national perspective, but also international. We have a client that just moved recently from UK, but they have national wealth back home in their country and not sure what they're going to do with it. So speaking with our team, we're able to help them on international tax saving opportunities, but also building new life, new career, new wealth in Canada, which is equally as important. With our services, we're able to help anyone from studying for medical school and grabbing their licenses, working as self-employed in different clinics, or someone that already has 2, 3, 4, 5 locations, and they want to grow even more persuaded in Canada. So this way, we're able to help them in all stages and levels. Why is that important? Because we work really hard. Just like you, I'm a chartered accountant. We put 8 years of our life into our profession. We sacrificed a lot. Now's the time when we can profit from this. Now's the time when we can earn what's due to us. It's equally as important we learn how to save most of it. It's important to preserve our wealth. And it's also important to think about generational wealth. So this is something that our team does a really good job of spending time one-on-one with each client, understanding your story, understanding where you're coming from, and what can we assist in order to achieve your goals. Leading to our 5-step plan, and it's talking about retirement, if you're in the next stage of your career. We're talking about investment management from a national or an international perspective. We talk about tax planning, which is equally as important, asset protection, and also estate planning. As we have moved here, we may have elderly parents, or we may be reaching a point where we want to talk about estate planning. Without going into too much detail, I'd like to pass the mic to my partner, Rastu, who's just going to conclude the conversation.
Partner's point, our ideology was to build out a family office essentially for medical professionals, to kind of close the gap that you would face dealing with all the professionals that you're dealing with, financial planner, wealth manager, tax planner. And want to bring everybody under one umbrella and essentially offer that as one service to you. So you don't have to go elsewhere to look at opportunities that exist. And as a token of appreciation, we thought of having an exclusive dinner where we host you guys in a group of 10, and we bring in professionals from all over Canada and US to kind of educate you on the things that we are able to do versus our competitors. And our message really is how to outsmart tax and how to grow your wealth, whether that's in Canada, UK, back home, wherever it is. So do us a favor and scan the QR code and make sure you're attending, because that's complimentary. It's on us. We just want to make sure we give back before we ask. Unlike everybody that offers a product, we like to kind of educate you first on why us before we ask for anything in return. So I thank you for the time you've given us, and hopefully we'll see you at the dinner.
X, so they are going to be helping us with the IMG. Thanks.
Question, how many IMGs again do we have in the group that are not yet practicing? So I am not Nigerian, but I went to school with Nigerians. I was in medical school with Nigerians, I work with Nigerians, I live with Nigerians, I've had your jollof rice, your puff puffs, I've had your pepper soup. It's not Nigerian, it's African, isn't it? I'm representing MRX. MRX is an event company. I myself am an IMG, but I grew up here in Toronto. Quickly want to tell you that if you are an IMG, whether you're looking for licensing or practicing, the landscape has changed for IMGs. Some of you who are practicing in the room will know this. It was very difficult. We heard the stories. The world is slightly changing. It's becoming a little bit more accessible, and the powers that be, the larger licensing credentialing bodies nationally, provincially, have made it a little bit more accessible. And so for that, we put together now the largest speaker conference and trade show in the country. We have over 50 exhibitors from the Medical Council of Canada to the Royal College to the College of Family Physicians. We have finance services, immigration services, board prep, exam services. So if you're an IMG, come see us in the back booth. I'll give you a discount code so that you can use it to get tickets, because we have our early bird wrapping up at the end of the month. If you have any other questions, we're happy to answer them. The goal at the end of the day is what I think most of you will understand, that in this country, and I was telling Dr. Itua, that unlike other races and cultures, the Nigerian community has done a phenomenal job putting something like this together. If only other cultures did something like this, you do deserve a round of applause. I'm South Asian, I'm originally from Sri Lanka, and I wish my community did something like this. So kudos to everybody here that's involved, and I know that the annual family conference that happens out west is much, much bigger. So continue doing what you're doing. We hopefully look forward to seeing all of you at the IMG conference next